Clinical decision-making in stroke, emphasis on the lower extremity, assessing lower extremity function, analysis of gait, and treatment techniques. Before doing an assessment on any patient who has had a stroke, it's important to know different prognostic indicators. For the lower extremity, specifically, active range of motion and strength scores at 30 days post-stroke have been shown to be indicative of overall recovery. For example, at initial onset, if a patient is unable to flex the hip independently, they're unlikely to ambulate independently with or without a device. Similarly, if the patient initially requires assistance for upright sitting, they will be unlikely to sit independently. An inability to sit independently can correlate to an inability to sit up in their wheelchair safely or eat at the dinner table. Your initial evaluation of a patient, combined with your knowledge of these prognostic indicators, is how you know what to work on and how much you think they might recover. There are a number of common lower extremity impairments that we'll be addressing in this lecture. They are hemiparesis or weakness, available range of motion, sensation, the presence of spasticity or flaccidity, balance, functional mobility, and gait. To begin, we'll have a discussion of weakness or hemiparesis. There are a number of common patterns of weakness following stroke, including weakness of the hip flexors leading to an inability to advance the limb during gait, weakness of the knee extensors, weakness of the dorsiflexors, which can lead to a toe drag or stumbling during gait, and weakness of the hip extensors. In large muscle groups, another consequence of hemiparesis is decreased weight bearing on the legs, meaning that the weakness leads a patient to either be unable to or hesitant to stand on their limb. There is even a perception issue here. Even with cueing, a patient's sense of effort versus the actual force that they produce on the limb is different. So for example, if you ask a patient to stand up from a chair and they think that they're putting all of their weight on their hemiparetic side, it's unlikely that they really are. Additionally, standing is very important. For patients who are unable to stand independently, it's still very important to facilitate weight bearing and to work on static stance, even with assist, as the more weight bearing you can get through your lower extremity, the more bone and joint stability and circulation you'll be able to facilitate. Range of motion, or a joint's ability to move through space and how far, is an important factor in someone's ability to function. We need specific degrees of range of motion to perform functional activities. For example, in order to stand up from a chair, we need 10 degrees of ankle dorsiflexion, 112 degrees of hip flexion, and 90 degrees of knee flexion. I choose a sit to stand because it's one of the most functional activities that we can practice. It requires more range of motion than most other motions that we perform throughout the day, and a chain of events is necessary to accomplish it. For example, without 10 degrees of ankle dorsiflexion, a patient cannot get their heels fully on the ground to stand and will not have the best possible base of support to push up from. Range of motion for functional activities is extremely important. The presence of spasticity and flaccidity can also have an impact on muscle strength, available range of motion, and overall function. Spasticity is defined as velocity-dependent resistance to passive stretch, resulting in an abnormal posturing of the limbs, stiffness, and decreased strength and control. Flaccidity is a complete absence of muscle tone or contraction, and in stroke is most commonly found in the ankle dorsiflexors. Later on in the lecture, I'll show you some video on how flaccidity in the ankle dorsiflexors can affect someone's ability to walk. In the lower extremities, though, it's important to remember that flaccidity can often be controlled using different types of bracing, which will be addressed later. This table just describes some common patterns of spasticity in the lower extremity. We can usually see an extension pattern or a flexion pattern. For extension pattern, we can see hip extension and adduction, knee extension, which results in a genu recurvatum, ankle plantar flexion, or subtalar supination. Flexion patterns commonly include hip flexion and abduction, knee flexion, ankle dorsiflexion, and subtalar supination. This slide just shows some pictures of some common spasticity patterns. What I want you guys to really see from here is the equinovarus, that you can see in the first picture on the left on the right foot. This is a very common pattern that we'll see, and we'll discuss some different ways that we can address this and allow our patients to walk more functionally. So far, we've discussed strength, range of motion, and abnormal muscle tone. So let's review and discuss some ways that those can affect our ability to perform different activities. Again, hip movement is a likely indicator of someone's ability to walk. If a person is likely to walk, they're going to have active hip flexion. They're going to have a palpable muscle contraction either with or without assist. If they don't have active hip flexion or any voluntary control of the leg, they're less likely to be able to walk with or without an assistive device. Sitting balance and trunk control are also important indicators. Someone is more likely to walk if they have volitional trunk control. Volitional trunk control allows us to hold the trunk upright while we're standing or walking, and forces the body to use less energy when doing so. Conversely, if someone is unable to hold themselves upright without assist, they're unlikely to sit upright or walk, and this can significantly affect their ability to participate in daily activities, even those such as eating at the dinner table or sitting safely in their wheelchair. We can also have range of motion problems that will persist. Spasticity or increased muscle tone can lead to decreased available range of motion and contracture. Joints that have contracture are unable to move through a full range of motion and can affect our ability to efficiently move throughout our environment. Flaccid paralysis, to the extent that joint position cannot be maintained, is also an issue. With the lower extremity, though, there are a lot of options for bracing or external assist to help maintain a functional position. Let's move on now to balance and coordination. We know that falls are a major risk for patients who have had a stroke. In recent surveys, 72% of people report at least one fall up to 1 year following a stroke. And balance and coordination can have a direct effect on risk of falls. When assessing a patient's balance, we do it in a specific order. We first assess sitting balance, then standing or static balance, and finally dynamic balance. Within each of those realms, we add different challenges to simulate real-life scenarios. Coordination is another factor that is involved when we're trying to perform a functional activity. It's generally described as a person's ability to place their limbs where they intend to. Ataxia is a common impairment following stroke. It's a general term describing errors in movement involving range, force, or metrics. So if we look at the picture here, we see a yellow circle and a purple circle. Someone with ataxia would maybe try to move their finger from the yellow circle to the purple circle. But rather than moving in a straight line, they would move in an unpredictable pattern that's not the most efficient way to accomplish the task. So that would be an example of ataxia. Similarly, dysmetria describes difficulty with judging the distance or range of movement. Both ataxia and dysmetria can be assessed using different types of tests, including finger, nose, finger, rapid alternating movements, and toe tapping. Let's all take some time now to practice some of these different tests and see what they can look like with different types of patients. The first step in assessing somebody's balance is sitting balance. You want to first begin in the most stable position, which is the patient in sitting with hands and feet supported. You want to assess how much assist that person needs to be able to sit there. If they're able to sit unsupported, then you can gradually add different challenges. You can unsupport their hands by asking them to place them in their lap. You can move their feet off of the ground by raising the bed or putting the feet on an unstable surface. You can ask them to open or close their eyes. You can have the patient sit on an uneven surface, or you could have them reach for an object that's about 10 inches away. All of these correlate to things that someone might need to do during the day and are indicative of a person's sitting balance and stability. If a person is able to sit independently, then you want to move on to a standing balance assessment. And this is a description of somebody's ability to stand with or without support with a gradually narrowing base. You want to begin with the patient in static stance, so that's in their comfortable stance, however they want to have their feet, and assess how much assist is needed. Do you need to hold on to them? Are they leaning on you? Or are they wobbling or losing their balance? The first step is to try to get someone to be able to hold their balance in a static, comfortable stance without assist. If they can stand independently, then you can test their ability to hold each of these positions shown for at least 10 seconds. You start with feet right next to each other. You move to semi-tandem, tandem stance, and then a single leg stance. Within each position, then you can again add similar challenges as to when you were in sitting. You can ask them to hold a specific position with their eyes closed while reaching for an object or on an uneven surface. Following a standing balance assessment, you want to assess their ability to balance while moving through space. This is typically done for a patient with stroke when working with somebody's gait. So you want to think about, is this patient able to step forwards or backwards? Are they able to step to the side? You can ask them to step over different objects, or you can ask them to walk in a narrow base of support. A dynamic balance assessment is particularly important if you think your patient's going to be able to ambulate independently or with a device outside of their home. It can help you get an indication as to how well they're going to do possibly walking through a doorway, walking around on grass versus a gravel road or a paved street, or walking in a busy environment where they may be confronted with crowds or other distractors that could lead to taking a fall. An assessment of functional mobility allows us to know how much help a patient may or may not need moving within their environment. This includes an assessment of bed mobility, including rolling, supine to sit, and a patient's ability to relieve pressure, sit to stand, and transferring from one surface to another. A functional mobility assessment is a good indicator as to how well this patient is going to move within their environment and can also help us know how much education we may need to give their caregivers on moving in different environments throughout the day. If you've determined through all your previous assessments that this patient is going to be able to walk, then you want to commence with a gait assessment. We want to assess this patient's ability to walk with or without a device and with or without help from the therapist. There are a number of gait patterns that we can see from a patient who's sustained a stroke, and they vary from patient to patient, but there are some common patterns that we can identify. The first would be an extended knee pattern. This is when the hip extensors or the gluteal muscles are stronger than the knee extensors or the quadriceps. Or a flexed knee pattern, which is where the hip extensors or glute muscles are weaker than the knee extensors. Some other common gait impairments you may see at different joints throughout the lower extremity are insufficient dorsiflexion due to flaccidity. This can result in toe drag, foot slap, or foot drop. Circumduction of the lower extremity, genu recurvatum or excessive knee extension, hip hike, trunk extension, or external rotation of the hip. Let's take a look at a few patients and determine some gait impairments that we might see. As you can see here, this patient has already been fitted with an assistive device. Let's look at the patterns he uses. The most notable impairments we see here are hip hike, hip circumduction, and external rotation of the hip. There's also a little bit of a foot drop noted on some of his steps. Let's take a look at another patient who is 6 months post-stroke. Most notable in this video is the patient's severe toe drag. He is incapable of lifting his toe off the ground. This is an important component to address as this patient may be at a higher risk for falls. In thinking back to our previous slides, we know that flaccidity of the dorsiflexors is a common impairment following stroke and can lead to impairments like toe drag during gait. This patient would be a good candidate for possibly using some bracing to allow him to walk more efficiently and safely. Along with toe drag, we also see some circumduction and external rotation of the hip in order to clear the limb and bring it through swing phase. An important component of gait assessment or training your patient to walk is deciding which type of device they may need or if they need a device at all. There are some common indications as to whether or not a patient uses a walker or cane. For a walker, a patient needs a heavy level of assist. They will typically have instability in static stance. They'll require upper extremity support or moderate to maximum assist from the therapist to stand upright. They'll have poor trunk control. They may have some difficulty sitting upright without assist, but they will have both upper extremities available for use. It's important to remember that a patient with hemiparesis of an upper extremity is unlikely to use a walker as they won't have that extremity available to them for help. These patients will typically have bilateral lower extremity weakness, and they may or may not have difficulty with cognition. A cane is used for patients who maybe require a moderate to minimum level of assist. They require unilateral or possibly no upper extremity support to stand independently. They typically have hemiparesis of one upper extremity, so they're not able to use a walker, and hopefully they also have a strong unaffected side. Also, just as importantly is that they're cognitively able to perform a safe gait pattern using the cane. What's really important to take away here is that you want to provide your patient with the least restrictive device to be able to function. Put another way, you want the patient to do more work than the device. If you feel that you can safely train your patient to use a cane, you want to opt towards using a cane versus a walker, because the more the patient walks on their own, the better of an outcome they're going to have. Another important component to walking is bracing or orthotic support. This is going to be addressed in a later lecture. We've discussed quite a bit about flaccidity of the dorsiflexors and the resulting weakness and gait impairments that can result. Bracing or orthotic support can greatly improve functionality and safety during gait. The braces pictured below are for flaccidity of the dorsiflexors leading to toe drag or foot drop. Putting a patient in a brace like this can allow them to walk without stubbing their toe or stumbling. It can also provide increased stability to the knee and decrease energy expenditure during walking. This can greatly improve a patient's gait pattern and thus improve their stability and efficiency when walking. We'll move on now to some different treatment techniques addressing the impairments that we've discussed. Specifically, we'll discuss treating strength impairments, particularly large muscle groups, as well as facilitating weight bearing. Range of motion, which typically involves using active assistive, or passive motion to preserve necessary joint movement for functional activities. This is particularly in response to spasticity or flaccidity that may limit joint range of motion. Functional mobility training, which is training on bed mobility, transfers, and sit to stand to improve efficiency, safety, and success within a person's environment. Balance training to improve postural awareness and decrease risk of falls. Gait training for safe and effective walking. And finally, education. Patients and caregivers need to be educated on safety, assistance needs, ultimate expectations for recovery, and limitations. We know that following a stroke, our muscles will still respond to strengthening, although it's important to remember that in order to achieve a training effect, a patient needs to be strengthening at or above 50 to 80% of their one repetition maximum. Essentially, a higher intensity is often necessary to drive a real functional gain. As we've discussed in other lectures, improving strength alone may not necessarily correlate to a functional improvement, so we want to make sure that our strengthening parameters are within what the research tells us is effective. Weight bearing is also an important component of functional strength. Although some patients may not be able to walk or stand independently, weight bearing can make a big difference on bone and joint health and circulation. I would encourage you to always work with standing weight bearing and sitting weight bearing through the limbs in order for the patient to preserve as much function as possible. Strengthening can be achieved in a number of different ways. You can use weights, bands, machines, or body weight to improve strength in larger muscle groups. You can also use different functional activities as strengthening exercises. So let's all think about some ways that we can strengthen the following muscles. Let's think about the quadriceps, the hip abductors, the glutes, and the calves. Now let's think about some functional activities we could do that also incorporate those muscles. Beyond knowing that we need to strengthen our muscles, there are some other strengthening parameters for muscle endurance and general strengthening. For muscle endurance, or for allowing your muscles to work for a longer period of time, we want to use a lower weight with higher repetitions. For example, 2 sets of 20 to 30. For general strength and muscle hypertrophy, we want to use higher weight and lower repetitions. For example, 2 sets of 8 to 12. Generally speaking, you always want to do 1 to 3 sets of 10 to 15 repetitions. As a patient gets stronger, you want to gradually increase their resistance. Remember that these patients will improve their general strength. So don't assume that they will always stay at the same weight or same number of repetitions. You also want to make sure to address multiple large muscle groups. The quadriceps, the hips, the glutes, the calves, and the dorsiflexors are all important components to functional mobility and walking. Strengthening the quadriceps alone isn't going to help someone advance their limb forward. We've discussed how impairments to range of motion can affect our ability to perform functional activities. Both spasticity and flaccidity can lead to stiffness and decreased range of motion in the lower extremities. Again, to stand up from a chair, we need 10 degrees of ankle dorsiflexion, 112 degrees of hip flexion, and 90 degrees of knee flexion. So whenever able, you want to incorporate regular stretching into your sessions as needed to avoid adverse events, or possibly use bracing or, again, serial casting to help patients maintain as much functional range of motion as possible. When training someone in different functional mobility tasks, we use a task analysis approach. We observe the patient performing the action and then teach and guide them to execute the movement as efficiently and safely as possible. The most important movements to assess are rolling, supine to sit and reverse, and sit to stand and reverse. For rolling, this is describing rolling from a supine position over to the side. You typically want to start by reaching across the body with a strong upper extremity and turning the head to the side that you want to roll onto. If the arm is flaccid, you can use this method to begin upper extremity weight bearing. You then want to push off with your strong leg to facilitate a roll onto the weaker side, or bend both legs up and allow your knees to fall out to the side. If a patient's having difficulty with this, remember that as a therapist, you can help facilitate a roll. You can either position their shoulder blades properly or position and help to move their hips. Remember that you want to control them centrally and direct them distally. There are 2 different methods that you can use to train your patient to move from supine to sitting. You can start with the side-lying method. So after a patient has achieved a roll onto their side, you ask them to bring their knees to their chest, then drop their feet off of the edge of the bed, pushing up with their arms to help sit upright. The physical therapist can help with pelvic control and trunk support if needed. This might be the most optimal method to use for patients who have more upper extremity involvement. If the side-lying method is not effective, you can use the long sit method. For this particular method, the patient starts in supine. They prop up onto their elbows, dropping one leg off of the table, and then come up to sit as the leg is lowered to the floor. This is most beneficial if you have patients who have perhaps bilateral lower extremity involvement, but do have good use of both of their upper extremities. Finally, we've discussed moving from sitting to standing in the context of necessary range of motion, but it's also an important functional task that patients need to be able to perform. We perform moving from sitting to standing in a stepwise fashion. We ask the patient to scoot to the edge of the chair, place their feet slightly behind their knees, lean forward, and then use their arms to push up. There are a number of sequencing mistakes that we can see during sit to stand, which include not scooting far enough on the chair, decreased anterior weight shift where the patient won't lean forward, use of knee extension to push off of the chair that they're coming up from, which relieves them from having to use their glutes, or poorly positioned feet. An important thing that I do want to point out as well is inappropriate use of the arms. A lot of patients, particularly if they're standing up using a walker, will try to pull their walkers towards them or try to pull up on you in order to stand. You want to never allow your patients to pull their walkers towards them to stand. More often than not, this results in a backwards force, causing them to fall back onto the chair that they were sitting on, or sometimes fall to the ground. Earlier in the lecture, we discussed a number of different ways to assess a patient's balance and the relationship between balance and falls. What's great about that assessment is that what you find will drive your treatment. We also know that exercise programs for dynamic balance training and multisensory and agility tasks is effective in preventing falls. When we're training someone's balance, we want to remember the importance of error. Balance training should be challenging but not impossible. For example, if a patient is able to stand without any assist and without wobbling, that's too easy. If a patient is able to stand in tandem, but they fall immediately upon you letting go, that's too challenging. You want to make sure that a patient is sufficiently challenged without compromising safety. If indicated by your examination, you want to test your patient and train your patient in sitting, standing, and dynamic balance. Remember to incorporate a variety of challenges for the patient. Ask them to open their eyes or close them, have them sit or stand on a firm or soft surface, or have them try stepping over objects. You can also incorporate functional activities like picking up objects from the floor, reaching for things with or without support, or opening and closing a door. Another component of balance training and fall prevention is education. You want to make sure to educate your patient and caregiver on different safety concerns. This could mean different scenarios in which the patient may or may not be safe, an environmental assessment or modification, including looking at different trip hazards in the home. This could include removing throw rugs or making sure that floors are clear of debris. And finally, proper assistive device use and safety. While we want our patients to be as mobile as possible using their assistive devices, it's important to remember that improper use of an assistive device is just as dangerous as not using an assistive device at all. If, based on your initial assessment, you've decided that your patient is going to be a candidate to walk, then we're going to want to initiate gait training. Gait training is more than just walking. We know that walk speed is a predictor of overall function and is a predictor of survival in older adults. We also know from the literature that a structured program focusing on specific impairments, whether at home or the clinic, will facilitate increased walk speed. Gait training can encompass a number of different movements. So after assessing how a person initially walks and what assistive device they may or may not use, you're going to want to consider using tactile cues on the hips to induce a weight shift onto their weak side, manual movement of a hemiparetic limb if they're not able to do it themselves, or different verbal cues for efficiency. It's also important to remember that gait is not just forward motion. You want to address sidestepping, walking backwards, stepping over objects, and negotiating stairs. Consider gait training of the patient here in the video. She demonstrates a left-sided hemiparesis of the upper and lower extremities. Let's take a look at how this therapist uses different strategies to help her to walk more independently. As you can see, the therapist was giving the patient both trunk and upper extremity support, as well as helping her to advance her limb. Although it may seem like the therapist is doing most of the work here, it's important to encourage as normal of a gait pattern as possible, even if that means using a compensatory technique in order to walk. Now let's watch the same patient later on in the session. As you can see, that patient was just able to achieve independent initiation of their hemiparetic limb. Although we saw some genu recurvatum or extreme knee extension, that patient was able to volitionally move her hip against gravity to move her limb forward. This was the result of 45 minutes twice per week of gait training with this therapist. In looking at this video, let's now think back to our prognostic indicators. We know that if a patient has some volitional hip flexion, that they are likely to be able to walk. Although the previous video showed the patient as needing total assist to advance her limb, in this video she now has volitional hip flexion. This shows a significant increase in her likelihood of walking independently. Along with that, let's discuss why this patient is ACE-wrapped into dorsiflexion. It's important to remember that if a person isn't capable of achieving full 10 degrees of dorsiflexion or even neutral dorsiflexion during walking, that's not going to allow them to extend their knee. If this patient was stuck in plantar flexion, she would be walking on her toes with a knee flexed posture, which would again impede her ability to advance the limb. By using a number of techniques, including compensatory bracing or wrapping, tactile cues, and pushing the patient to independently move her limb, we've resulted in an improvement in her gait pattern. Along with a functional skill therapy program, aerobic exercise is and continues to be an important component of functional recovery. We know that the risk factors for stroke in Ghana include hypertension, high cholesterol, diabetes, and obesity. Those things don't go away once we've had a stroke. And just as cardiovascular fitness and endurance is important for folks who have those afflictions prior to having a stroke, studies support that cardiovascular training can also help to improve overall function after a stroke. You want your exercise to be intense enough that it results in an elevated heart rate, a faster respiratory rate, and possibly even perspiration. It is okay for these patients to sweat. Dosage can vary, and there are a number of different programs that can be effective. Even as little as 3 to 5 sustained minutes of endurance training multiple times per session or per day can help to improve cardiovascular fitness. So let's try it. Everybody think of some ways that you can work on cardiovascular fitness with your patients following a stroke safely and effectively. When you're exercising with any patient, and particularly a patient with stroke, you do want to make sure that you're monitoring vital signs to make sure that they're safe. The table below describes some contraindications to exercise. This means that if any of these things are true, exercise should be terminated immediately. This includes a resting heart rate of more than 100 beats per minute or less than 50 beats per minute. Resting indicates when the patient is sitting still and not performing any activity. Also, a systolic blood pressure of greater than 200, a drop to less than 90, or a drop of greater than 10 indicates that exercise should be terminated. A diastolic blood pressure of greater than 110. If the patient's O2 saturation goes below 90, or if the patient begins to experience symptoms of shortness of breath, angina or chest pain, dizziness, severe headache, or sudden onset of numbness and weakness. It's also important to remember that we know that once a patient has sustained a stroke, 14% will sustain another stroke within the next year. So it's important to remember how to identify a stroke and know what to do if somebody is exhibiting symptoms. You want to remember your face, arms, speech, and time acronym. And if you suspect that a patient is having a stroke or another cardiac event, make sure to call emergency immediately. Let's now go through some cases of different patient examples and decide what we would want to do for a typical treatment. Patient 1 is a 65-year-old man presenting 4 weeks post-stroke with flaccid dorsiflexors on the right, 3+ out of 5 hip flexors on the right, 2- hip abductors on the right, ability to sit upright without assist, and ability to stand with minimal assist from the therapist. He is able to perform a sit-to-stand by himself, but it is difficult. He has full strength on this left side. What are some things you would want to work on with this patient? For this particular patient, their available strength in the trunk and lower extremities indicate that he is likely to walk independently. You will want to consider bracing to help with toe clearance, as he does have flaccid dorsiflexors, and a cane to improve his stability as his left side is intact. This person will definitely benefit from further strengthening to improve sit-to-stand. That can mean functionally training the patient to perform a sit-to-stand, as well as strengthening the lower extremity muscles necessary to execute that movement. This patient is a good candidate for standing balance training to decrease his risk of falls. He's able to stand independently without assist, so this would be a good person to add some challenges in the eyes closed or compliant surface category. Finally, as his prognostic indicators indicate that he's likely to walk, you're going to want to initiate gait training for efficiency and safety. Now let's discuss patient 2. Patient 2 is a 75-year-old woman presenting in your clinic 4 weeks post-stroke. She requires minimal assist to sit upright. She has very little active use of her hip flexors, is max assist for sit to stand, and is unable to stand without use of both of her arms to hold her up and help from you. She is currently max assist for all bed mobility. What will we work on with this patient? This patient is a candidate for compensatory strategies and caregiver education on decreasing the amount of assist she will need in daily activities. She will likely be in a wheelchair for most mobility. However, that doesn't mean that we shouldn't work on standing balance and other strategies to improve her ability to move. We will want to work on sitting balance and strengthening of the abdominal muscles. This is important so she can be safe in her wheelchair and perhaps sit upright on her own. Upper extremity strength so she can propel her chair. You're going to want to functionally strengthen the lower extremities so she may be able to stand using a walker for short periods of time. Although she's unlikely to ever stand independently, we do know that weight bearing on the lower extremities will improve bone, joint, and health, as well as encourage circulation. And finally, you're going to want to address functional mobility training and strategies. She may never be independent in those things, but if she can move more efficiently in bed, it's possible for her caregivers to have to do less work in order for her to move throughout her environment. Today's lecture was focused on common impairments of the lower extremity following stroke and different decision-making skills on how to treat those patients. Throughout the lecture today, we discussed common impairments of the lower extremity and evaluation of those impairments. We identified prognostic indicators of function and integrated them and how to integrate them into your treatment. And hopefully you now understand different treatment techniques for identified impairments. Our patient cases were descriptions of 2 very different patients and how although they had differing levels of function, there is still a wide variety of things that we can do to help those patients move more independently and safely, as well as more efficiently. Thank you for your time.